Everyone, welcome to Socrates Cafe. Thank you for joining us today. This event is hosted by Theta Kappa, and I just want to give you a little bit of information about what that is. We're the honor society of the two-year community college. If you'd like more information about becoming a member or other things that we do, we'd be happy to share that with you after the event is over. So right now, we're going to get started, and I'm going to introduce Catherine to you. She's joining us today, and she's going to give you some information to get us started off.
Okay, thanks guys. So I'm Catherine, and I am here to talk to you a little bit about the healthcare reform, also known as Obamacare, also known as the Affordable Care Act, aka the ACA. And so I'm going to be telling you a little bit about what the law is from a couple of different perspectives. One, my own personal history, so what it is for me living in a world where I've known people and I've met people who don't have health insurance and haven't been able to afford health insurance. For my work, I am currently an in-person assistant, so I'm helping people sign up for health insurance and getting to hear a little bit of their stories and how much this law is impacting them. And then also I am in school right now for public health, and so I'm going to give you a little bit of the more systems view of this law to kind of give you a better understanding of why do we even have this in the first place. So let's look at the healthcare law. So this is a graph looking at the U.S. compared to some other developed countries. As you can see from the red line, I don't know how well you can all see this, but the U.S. per capita spending on healthcare is grossly higher than any other of these developing countries. All of these other countries actually have universal healthcare, but we spend a lot more on healthcare. The reason for that is a couple of different things. Some of it has to do with the way that we deliver healthcare. We deliver it in this sort of isolated systems. A lot of this, about 25% of our excess cost is due to administration. So, but you would think, because we spend so much on healthcare, that we should have really great outcomes. We don't. So when we compare the US to these other countries that have universal healthcare, that spend less per capita actually on healthcare, we see that the US, I don't know if you guys can see this, but the US, this last little slot, it shows you how the US has been rated in comparison to these other countries for their healthcare delivery. And we're pretty low. We're actually the lowest in things like quality care, access, efficiency, and equity. So all of this kind of helps spawn the creation of healthcare reform. The ACA does a lot of things. Most of what we've heard about is the website, and we've heard about people signing up, or we hear about the cost of healthcare delivery. But the ACA is kind of like this pronged approach that attacks healthcare from different aspects. So what it does is it actually has reforms for healthcare delivery. It has reforms for, access to healthcare for consumer protection, so looking at the insurance companies, and it also has reforms for how we are able to access health insurance, so the cost and the availability. So what I want to talk a little bit about is paying for your plan. So the number one reason that people across the United States say that they don't have health insurance is because it's expensive. And the reality is that it's not just, this 18 to 35 that don't have health insurance. In some states, 20% of people who are 18 and younger don't have health insurance. So that's 7-year-olds, 8-year-olds, 12-year-olds. And it also impacts people as they get older as well. So what the ACA does is it basically helps lower the cost of health insurance for the most vulnerable population. So for the people who can't really afford it. So if you make under $16,000 a year, most likely you'll be eligible for free health insurance in Washington State. If you make under $45,000 a year, you'll be eligible for like tax breaks, subsidies. It'll be reduced for you. So I've been signing people up, and I can't say universal how much it costs. But what I see when people are paying for plans is it costs about $45, $50 a month. Not that bad. So this is a breakdown of our federal poverty levels across the United States. So to be eligible for Medicaid, you used to have like a predetermined, you had sort of like a qualifying factor. You had to be pregnant, you had to be disabled. Now what it is in Washington State, since we have decided to expand Medicaid, it's all based on your income. So if you make under that 16,000, no matter who you are, you can be a single parent, you can be an adult, you can be a mom, you can be a student, you are eligible for Medicaid. And so that just shows you that there. Okay, so choosing a plan. So the ACA also made sure that now across the board insurance plans have to do something. They have to cover 10 essential health benefits. Prior to the ACA, there was nothing like this. Women would actually have, this is kind of wild, but 63% of women who had an individual health plan, so a plan that they bought on their own, it didn't cover maternity care. Now, of course, not every woman needs maternity care, but some women do. And so what the ACA does is it said there are these 10 essential health benefits that every plan has to offer. There's things like maternity care, but there's also things like prescription drug coverage, hospitalizations, emergency visits, and things like rehab and rehab, like physical rehab, and then also rehab like drug treatment, counseling, and mental health services. So this is true in all cases, in terms of Medicaid plans, and in terms of plans that you get through your employer. Those have all been reformed, and in terms of plans that you buy through the healthcare exchange. So what the ACA did is it also made it really sweet for states to expand their Medicaid program. In some cases, states chose to do that. In other cases, they didn't. So the reason that states were kind of like incentivized to expand their Medicaid program is they were given, so with Medicaid, new Medicaid recipients, the federal government will pay 100%, actually it's about 90% of the cost of those Medicaid recipients. So the federal government is helping states to basically cover their vulnerable populations. Not all states have chosen to expand Medicaid, but Washington State is one of them. So this is what the website looks like. In Washington State, we chose to do our own state exchange. Other states actually chose to use a federal exchange. The Washington State Exchange is doing really well across the board. And the website for this is wahealthplanfinder.org. So when you go onto these sites, you can sign up for health insurance on your own. You just have to create an account. You'll enter the same information that you enter when you're signing up or like filing your taxes, and maybe with one or two questions about your health. So that being, are you pregnant and do you smoke? You can also go to a variety of places in the community that I think that we are going to talk about next. So yeah, this is kind of, the healthcare reform came about from this place with the United States really struggling in terms of how do we deliver the best and most appropriate healthcare for our community. And it's done a lot of different things, and just one of the pieces is the health insurance exchange. And it's, I think we're going to hear more about that and what our community is doing.
That's a great slide to leave up for the duration because it reminds you where to go online to get help. I'm Carrie Ranton. I'm the Director of Planning and Marketing for Skagit Regional Health. We have Skagit Valley Hospital here in Mount Vernon and a series of 10 clinics around the region. And so to really take off from where Catherine left off in terms of the big picture, the national picture, the state picture, and where we are, we have a community picture and a community story to tell. And here in Skagit County, we have 18 to 20% of our residents are uninsured. And so we have a ways to go, and this is a real opportunity for many of those people. We set a goal as a community, as a county, to enroll just over 6,900 people over 18 months in the programs that we've just discussed here. So far, through the most recent data I have is through November of 2013, and we had hit right about 2,500 people, I believe. The vast majority of those people signing up here in Skagit are signing up for Medicaid, so they qualify for the programs that were just described for those who have an income on the low end. And so they are taking advantage of that Medicaid expansion, which our state decided to go with and get that federal help so we could improve that coverage for more of our residents. So this has been really a community effort here in Skagit County. We have banded together public health, community action, Planned Parenthood, all of the hospitals, that Island Hospital, Skagit, and United General, and we've come together to provide opportunities for people to sign up and have people trained as in-person assisters. They're just a phone call away. We have materials here, and if you go online to any of our websites locally, SkagitValleyHospital.org, etc., you can find those phone numbers as well. So if you get into the website and you find it to be a challenge, know that you're not alone, and know that there are people there at the other end of the phone to help you. We are also working on coordinating some events where people can come and get signed up. I know we at Skagit have evening and weekend appointment times for people to come and get help signed up. So one of the real goals, though, and why it's important for people to have insurance is the next step that one should take after you have insurance, and that's getting signed up with primary care. Prevention, wellness, chronic disease management, all of those things are so essential today as healthcare reform moves down the path. This is going to take some period of time to fully roll out healthcare reform, which at the end of the day has a goal of keeping people out of the hospital, out of the emergency department, out of those high-cost areas that have driven up the cost of healthcare in our community and in our country, as displayed on that graphic earlier. So the ultimate goal is to provide people with preventive and wellness care, keep people healthy in their community, do that in a community fashion, and at the end of the day, then those costs are going to come down. So we're going to get both goals out of it: improved health and wellness and lower cost care. So it's always our goal to have high quality care, and we certainly aim to do that. One of the things that we're doing at Skagit, so we've got an influx of people with insurance, we've got an influx then of people calling and needing to find a physician. And we've seen that at our physician referral phone line at Skagit. We've got people who say, hey, I've got insurance, now I need a doctor. And that's terrific. That means the program is working. That's exactly what we want to have happen. So as I mentioned, the ultimate goal is community wellness, and there's kind of a term out in the world, population health, and that's really what it's all about. Having healthy communities and working together to do that. We're seeing some really great work going on in our own community, and I think we can all be very proud of that and take advantage of the great work that's going on. A lot of creative thinking around how do we manage patients and keep them at home and keep them well and keep them healthy. Things like looking at the idea of social workers and case managers reaching out to patients in their homes and making sure that they're taking their medications, have access to the services that they need and the resources that they need, and keeping them well and healthy at home rather than coming through the emergency department with another acute episode as a result of a chronic illness. Something we're kind of exploring right now that's interesting is working with the EMS system and fire department. There are excellent programs and models for this around the Northwest even, where during downtime between calls, these providers of emergency care can go out in the community and do home visits and home assessments, stop by and see a patient who's known to be perhaps at risk for being a fragile condition, and check in on them, make sure things are going okay. Again, making sure they're taking their medications and that they have the resources and help they need. So those are going to be some of the ways that we come together as a community to really address the healthcare needs of our whole community. And as was mentioned earlier, rather than doing this in a siloed system of health system over here and this program over there, banding together and having those network together and work together for the benefit of the patient. So I think courtesy of healthcare reform and the Affordable Care Act, you're going to see some very interesting ideas and models of care out there that are embraced in communities like our own. And it goes way beyond healthcare too. It's about transportation, it's about housing, it's about all those other needs that people have to make their life a healthy and successful one. So insurance is one piece of it, and it's an important piece of it. But then there's that next step, as I said, of getting access to care and getting involved with a primary care provider, so people can start on that path to wellness. And so it's really an exciting time. And yes, there has been obviously a lot of information floating out there about the difficulties of signing up and some of the challenges that the websites have had. But I really think that those are beginning to smooth out. We're seeing a lot of people having success getting in and getting signed up. I'll mention our residency clinic again. We've had patients pretty much on a daily basis calling and saying, just got insurance January 1, I'd like to make an appointment. And so again, that means that the system is working. That's what we want to have happen. So here in our community, there are a variety of places you can go to get help or call for help to get signed up for insurance. And that includes not only Skagit Valley Hospital and Planned Parenthood, but Community Action, Island Hospital, CMAR Community Health Center, United General Hospital in Cedar-Woolley. And they all have phone numbers and websites and such that people can tap on us to get the help that you need to get signed up. So I think it's an exciting time to be in healthcare. I think our community here in Skagit County is particularly banded together to do what we need to do right now to get people signed up, then provide them with access to care, and then surround them with the system and the network of services that people need here to be able to be healthy and well going in the future. And at the end of the day, then that meets up with both of the goals that we have, not only great quality care and healthy people, but bringing that cost down and making it more affordable for all. So I think we're really moving in the right direction. And I think Catherine and I would be happy to answer any questions if you have them. So come up and join me and let us know, or even comments or things that you've heard, anecdotes you hear in the community. It's important for us to know, not just from our own perspective how things are going, but how is it going from your perspective.
Okay, so I heard that the ACA will do away with the DASA, that it's going to pick up substance abuse treatment in another way. Can you talk a little bit about substance abuse treatment, please?
Well, I don't know, what did you say, DASA?
A DASA, that's the current program that's in place. What I know a couple of people who have signed up for it. They just go down to DSHS and fill out a couple forms, say they want to apply for a DASA. I forget what it stands for at this time, but it's
okay. So I don't know that program too well, but I can speak in general in terms of kind of what the ACA has done to some of our community like programs, and also what it's hoping to move towards.
Okay.
So in some cases there have been cuts. There's been cuts towards certain programs that provide care for people who don't have health insurance. And it sounds like there have been cuts to this program for substance abuse. So then what the ACA aims to do, or hopes to do, is actually expand those programs. So instead of providing substance abuse treatment to a selected group, it's available through everyone through their insurance, from my understanding. And so there is some concern about they're called the safety net providers, our safety net providers, whether or not they'll still have the resources and the funding to take care of our community. And so this is something where right now there's been, from my understanding, no huge cuts across the board towards things like, like I know about like Title 10 and things like that. There haven't been these cuts yet, but it's things that we need to be mindful of and thoughtful to and pay attention. So yes, I think that is a big concern, but from my understanding now, insurance will be covering those kinds of services. Yeah.
Good question. No, that's good.
Okay.
I got it already. Adult dental, you mentioned, or I saw in the 10 essential health benefits slide that pediatric dental was there. Can you speak about adult dental, please?
Yeah. Do you know anything about that, or do you want me to? Go ahead. Okay. So what I know about adult dental is, so currently, this is sort of interesting, is that a lot of kids actually don't have dental coverage. So for all parents who use the healthcare exchange, they can sign up their kids for health insurance. They also have to sign up their kids for a dental plan. It's something that it's an essential benefit. For adults, dental coverage, from my understanding, is not one of the 10 essential health benefits as of right now. I think there's this idea that it might be in the future. For Medicaid, everyone on Medicaid has dental. This is something that surprised me. I didn't actually know. So people who have Medicaid, dental is covered. But yes, I think that it's something that, from my understanding, it's not one of the 10 essential health benefits right now.
So is that something that you need separately from?
I think so. Okay. I think so. And it's something where, honestly, like these sort of more nuanced questions, there's on the website, there's like this little link where it says like talk to a navigator, talk to a broker. Us as navigators, we're really trained to help you sign up. we might not know sort of the subtleties of the different health plans, but brokers are really much more like trained in the sort of the nuances of the different insurance plans, and they can help you pick which plan's best for you. I, as a navigator, I can't say to you, pick this plan, it's great, this one covers everything you need. But a broker can actually do that, and they're completely free, and they're available through our community, so.
So I actually have a question. Carrie, right?
Okay.
Hi. Yeah, I guess my question would be for you is since you're obviously kind of working in the community or focused more here in the valley. Where else I work is the YMCA, and I deal with a lot of people who are older adults who come in and they have what we call a Silver Sneakers membership. So they basically pay their insurance, and the insurance gives them to work out for free. And so what I've noticed actually from the first is a lot of the people that have been continuously coming in and being able to participate in that program is a lot of the insurance is that they've had have actually cut them off from that and switched them to another. So I don't know if you know like kind of what the ACA is doing to kind of help with that or move on from that and maybe bring them back into it? Or?
I don't know the specific answer to the question, kind of like what you were saying, Catherine, the
Okay.
nuances of each. That is disappointing, I will say, however, because what a great thing to motivate people of any age, but especially our seniors, to continue moving and being active and being engaged with one another in a social physical activity setting. So we can imagine that is nothing but a benefit to that individual and to the others in the group. So I would say that I'll look into that though and see where that fits. And again, in regards to our greater community conversation, that's definitely should be a part of it. Obviously physical activity, and again, at any age is of value. So that is a wonderful thing, and I know partnering with programs like the Y are going to be where we go in the future. So I will certainly look into it. It's
Okay.
very good comment.
Something I had understood from the presentation you had previously with you guys was that it was as younger, started to apply and do all this, and someone would start seeing some of those services for the elderly come back and right balance out. From what I understand.
I think the system overall, as we move into it, will find that balance, and you'll see the costs begin to come down for all ages. Now, that said, we do know that people use more healthcare services towards the end of their life, and less so at the beginning. But again, with the focus here on overall health and wellness at any age, you start that when you're young, you take on those habits, you avoid the not so great habits, and then, you become a healthier adult and a healthier senior. So this is going to be a transition that takes, many years in the making, but it's definitely worth doing. And as you say, I think at the end of the day, we're going to end up with a balance there.
Yeah, I think the only thing with that is for the most part, health insurance through the healthcare exchange is oftentimes cheaper than it has been prior to healthcare reform. In some cases, there's this little sliver of the population where it actually costs more for them, and that's usually people who make about over 45,000 and under about somewhere around like 60,000. Most of those people have health insurance through their jobs, but there is a small sliver of the population that it costs a little bit more for. I think that we can all understand what insurance, this idea of pooling. So it's pooling risks. It's bringing together all these different people and combining all of our risks to decrease the amount of risk that we have with this sort of collective. And I think that in some cases probably makes a few of you a little uncomfortable. I can see you shaking your head. So I would love to hear your opinion or your thoughts on that, or what are your feelings? Because I think it is an important conversation to have. And I don't mean to point you out if you feel uncomfortable in any way. Please don't.
Do you know the mean income in the area?
In this area?
Yeah.
No.
It's right there.
Okay.
So when you say the small sliver on a bell curve, you're talking about the largest portion of our population.
Yeah. Well,
so you say small sliver. Hello, that is the largest portion of our population in section
Maybe I
is
can-
right in the center of the
Maybe I can
population.
clarify a little better. So
Affected.
people who are using the healthcare exchange aren't people who have insurance through their job. People who have insurance through their job, they don't need to use the healthcare exchange. So those portion of the population most likely get insurance through their job.
Yeah.
This is really for people who they're self-employed, they're people who are not offered health insurance through their employer, or they simply do not work, or there's other cases that make it so that health insurance is out of reach for them. So when I say a small sliver, I don't mean that that's not the amount that people are making. I mean that in terms of who's using this healthcare exchange, it's people who are buying insurance as an individual.
That's true.
So,
Is the cost for insurance based on your income? I mean, I have insurance through my husband who's insured through his employer, so I haven't really had to worry too much about this, but just out of curiosity, are the health plans, the cost of the health plans based on your income level? Okay.
Yes, this whole setup here is based on income.
yeah.
So you put your income in, if it comes in at that level that you are able to apply for Medicaid, you kind of go straight down that path to the Medicaid application and get you signed up. Yep. The other thing about employed or not, sounds like you have, your husband has an employer that has a good program for dependents and spouses, et cetera. Some plans aren't as good, so you've got a spouse with coverage, but their spouse might be able to find a better deal on the exchange if their employer doesn't support the dependent side of the family as well. So you'll find situations like that too that could fall into those income brackets where they may actually find a big fix for money, but worth the exploration.
Do you have any information about states that just are not Medicaid? I have a anecdote that opened my eyes to what's going on in a big swath of the country. So my son and his wife live in Alabama, have 4 children. Children are on Medicaid, and the 2 adults have recently lost their coverage from change jobs from the individual country. So they assumed they would get coverage on the exchange. But when they log into the exchange from those states, not this state, it identifies them as being in the eligible for Medicaid income level, which eliminates you from being able to have the qualify for the subsidy. So either a family of 6 who are being told in order for the adults to have coverage, because now the kids already have Medicaid, but in order for the adults to have coverage, they pay $800 a month or something, and not qualify for subsidy. Whereas when they pretended they were just the 2 of them, they would have gotten $15 a month because they would have been in the right people body good. So with Benio, we talk about, generally nationwide, we talk about how you need to go get insurance, and most people with an income below a certain amount are going to get insurance for a discount, for subsidized insurance. And then there's a whole lot of people that fall into that category that they do. It's kind of interesting to me that it's not talked about, even though it doesn't affect us. So it is a piece of what happened in law being written to assume people were going to go on Medicaid, so therefore eliminate them from it. But the governors or whoever is saying,
Yeah. I think, does that make sense to everyone? So there's this idea of this 138%. And if you make below 138% in this state, you are eligible for Medicaid. The problem is that not all states expanded Medicaid. And so the federal government, in designing this, really thought that every state was going to expand Medicaid. Because they're really not put into a financial burden by expanding Medicaid. So what happens is that there's this gap between the amount of federal subsidies that are available for states that have not expanded Medicaid. Yeah. I don't know if it's, yeah, so from what I've at least heard and sort of the discussions that I've heard surrounding this is that it's a huge problem. and it's something that there is a move and an effort to fix, because it's basically sort of like the Medicare gap. Like there was this, so this fixed the Medicare gap, but it's similar to that where there's this gap. And I think it's a huge problem, and I hope that it gets fixed.
What they got told was by the Medicaid people, go ahead and apply.
Yeah.
Even though you're not eligible, because I think they want to make that application and say, look at all the.
Yeah, I hope so. Okay. Is there other questions?
Yeah, I guess I just have one other idea, something to ask you guys in general is, I know that for just health insurance, it's a good idea, obviously, to cover, everyone and to have everyone have great insurance for pre-existing diseases and also diseases that may transpire over the course of a person's lifetime. But is there any kind of plan to push more of a preventive type like motivation or kind of attitude within all these hospital or insurance companies to maybe give incentives to people to say, hey, like since I do work at the Y, to say, hey, with the silver sneakers, or even for younger kids to say, get off the couch or stop sitting in front of the computer, go in and, you get this incentive to go work out, and then ultimately down the course of that person's life, maybe running or walking during the day saves them from, I don't know, diabetes, or something to that effect.
From the employer side of that, and maybe you can address the insurance side of it, but from the employer side of that, I think you're seeing that happening with employee wellness programs, and the employer bringing incentives to their employees, and having the employees' portion of the premium based on their health and wellness and how they're doing with their physical activity level or their smoking cessation program or whatever it may be, because then at the end of the day, the cost is going to drop down for the employer, not only in insurance premiums for those employees, but also potentially for time lost due to being sick or injured or ill, because they are taking better care of themselves. So I think from the employer side, you're seeing a lot of education going on, even at a small scale, small businesses, how to get an employee wellness program going. There's some great online tools, there's some inexpensive tools, and you see some of the payers, some of the insurance programs, the group healths of the world, definitely have those kinds of programs going.
So do you know, not to cut you off, but so do you know the numbers, at least here in the Valley, or have you kind of seen some of maybe some businesses, or at least this already happening?
I can tell you one. I know my sister is a teacher at Everett High School, and she has so many, she wears something that keeps track of her steps, and she has to do so many activities, and she's always keeping track of stuff because of a health thing for her job. So I know Everett High School has some sort of health wellness.
My husband is going to say my
Washington employees insurance have wellness incentives built in, and the legislature just passed laws to implement more, including starting next July, all employees will pay an additional amount to their health insurance for smoking, or anybody in their household.
So that's the state of Washington, so that's a big group of employees. We're starting one at Skagit Valley Hospital. We're going to put in we hope to put in some equipment so that it makes it easy for people to exercise without having to leave campus if that is a barrier to them doing that. And we're hoping that with about 1,800 employees among us, that we can develop a model that we can roll into the community and help the community and small business perhaps be involved and show them the way to get those kind of programs started. So I think you're seeing a lot of that work going on right now.
So I can just,
yeah. So, but thank you very much for your time. We might take a couple more questions.
do you guys have any?
Yeah.
Actually, the last big reform was to bring in wellness programs for the HMOs.
Yeah.
Because the unique model was that they would say, you would just have a copay, you know, the deductible would be for speed, be able to access care immediately, and have access to preventive care that the insurance company was running.
Well, and I think just to touch on that is that you're so right in thinking about that there's ways that we can prevent illness, disease. The top 3 causes of death for both men and women are actually, in most cases, they're actually preventable. When you look at them, they say that the cause of disease is cardiovascular disease. But the real root of that is physical activity and diet. And so the reality is that there are things that we could do, and there's things that we should push for people to be doing to actually improve their health. And the ACA does that, just like she was saying, with encouraging a health and wellness program, but it also puts restrictions on hospitals. So hospitals used to have this idea where they could, they basically, the more that a person goes to get like a specialty service, the more that it costs for the patient, and the more money that it brings in for providers. So what they're moving towards is there actually is going to be regulations on hospitals and healthcare providers to see how many times are people coming in, are they coming in for the same thing, and are they really being treated for what they're coming in with? And so that's going to be a huge thing. So, yeah.
Whoa, so if someone has a chronic disorder that has nothing to do with their, that has nothing to do with their lifestyle,
Yeah.
then they shouldn't have to pay more and more as they continue to live with a chronic disorder. I'm not sure, I heard you right, that if they have something that they continually have a lifetime to deal with.
Yeah, so I can explain it a little better. So for example, mental health problems. So right now when someone has a mental health problem, they can go to the emergency room. And they oftentimes do go to the emergency room because there's not a lot of services available for them in the communities that they have access to. So they go to the emergency room. Sometimes they don't receive appropriate care, and they get kind of pushed aside. It's called boarding. And actually, in this community, we do board people, and in Washington, we board people. It's basically where you keep them in isolation and where they're just held for a period of time. So if that person comes back in a short period of time, based upon, and they come in that same reason that they're coming in for mental health services, and the hospital actually, the reimbursement rate that the hospital receives will be lower. And so it's kind of pushing hospitals to address the first time that person comes in, to address it. And so there's just a window. There's like, if that person comes in within like, I don't know what the window is, like let's say it's like 2 weeks with that same thing into the same ER, then the hospital will not get reimbursed the full charge. And it's this effort to instead of having people come into emergency rooms and not really treating them for the reason that they're coming in, and people it's because the same people are coming in and using the system repeatedly. And so it's an effort to try to stop that.
And what if the person is an epileptic?
I don't know if they would be coming into the emergency. If they were an epileptic, I think it would be well, I mean, I don't know. Now I'm speaking sort of like anecdotally from like my own thinking and personal ideas, because I don't know for sure. But I would say if somebody's an epileptic, actually, I probably just can't even answer that really.
I'm trying to think of something that would cause a, I mean, I can't even think of something off the top of my head, but that isn't a mental health situation, but would cause an emergent situation that would bring them to a point where they would need services, and it was beyond their control.
Yeah, well,
and
the
something
reality is that it won't affect the person. The person won't have to pay more. What happens, it'll affect the hospital the way that the hospital is getting repaid.
Just basically incentive for the healthcare providers to do their job in the first place. If it's something that they can fix, somewhat immediately, then it gives them more incentive to do that, because the next time a person comes in, because if nothing was done, they're not going to get the reimbursement.
And the cool thing is that hospitals will actually get paid more if they do meet these metrics. So hospitals will get paid, they'll receive these sort of like bonuses. So it does a lot of things to try to make it so that individuals receive the health care that they need. Yeah.
It just seems like what's been brought up kind of represents the whole story that's going on in the country.
Yeah.
About what's fair and what's personal responsibility and what's the common good wanted to maintain the competition of the marketplace is a big important thing that they make sure they had in there. So we were clear about that, and then the outcomes-based medicine with the emergency providers actually provides the kind of ongoing services that we need to do, which is what emergency is. And it's a national discussion on a lot of levels.
Yeah, it really is.
I think the reality is too, right, with something like this, you're not going to make 100% of people 100% happy all the time. It's just, that's not reality. So it's about, accepting that this is what it is and making it work best for you, I guess,
And you're ultimately, whether it's fair or not, if some person works out and eats right, so it's smoking, the other one doesn't, and they give it into their insurance, one's gonna get other rewards, Hopefully. So, yeah, there's that fair kind of thing going on.
Yeah, I think so. Cool. Is there any other questions, or?
I think I have one. Okay. So there's this, well, maybe it's a rumor, maybe it's not, that males are going to be asked to cover maternity care under the Affordable Care Act.
Yeah.
Is that true? And if so, what is the reasoning?
It's true. It is true. It's male, and this is the reason behind it is because with health insurance previously, women were paying more for their health insurance. It was actually, being a woman was kind of defined as almost like this condition, and your insurance coverage was more costly because we have certain health needs that men do not have. And so yes, it is completely true. Men are paying for women's health care. We are also paying for children's health care in some of our situations. We're also paying for elderly health care. So I think when we look at these 10 essential health benefits, we're also paying for other things like emergency care, even if we're not going to the emergency room. We're paying for prescription drug coverage, even if we're not using prescription drugs. And the true reason behind this is not because men are having to foot the bill for women's reproductive parts. It's that we have to have a way with our insurance coverage to ensure that every human being is covered, and that they're covered adequately and so that fairly, so that not women aren't covered in a different way than men are covered. And it really is, it's kind of the universal. Every other country sort of behaves in this sort of fashion. And from my personal perspective, I think that healthcare is a right. It's a right that we should all have. It's a right that every single human being deserves. And in some cases, it's true. We are paying for things that we don't need. But that's kind of what insurance is. That's what insurance is. So, yeah. Any other questions? So I ended it on that sort of note. That's what I really believe. So, yeah. Well, thank you guys so much for taking the time to listen to this. And you're wonderful.
So I want to give a huge thank you to Catherine. It was great to have Carrie here earlier. You guys gave so much good information, and it was really helpful to start the conversation. I think a lot of people are not talking about this, and that's where all the confusion and the myths and everything comes from. So I think we hope to dispel some of that today anyways. I want to thank everybody for coming. If you want to hear anything more about Phi Theta Kappa and other things that we do here on campus and off campus, me and Morgan are both officers, and we'd be happy to share any of that information with you. So thank you.